Welcome to the latest MS Hear from the Experts webinar. This webinar series is helping people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate their MS journey with more knowledge and confidence. Our intention is to help learn more about this disease, treatments, research, wellness strategies, our programs, and much more. My name is Shauna McKinnon, and I'm your moderator for this evening's broadcast. I've had multiple sclerosis since January of 1998 and recently retired a couple of years ago from almost 40 years in radio. So welcome to both our audiences, including those joining the broadcast on Facebook Live. MS Canada would like to acknowledge that we are on the unceded and ancestral territory of First Nations, Inuit, and Métis people across Canada. These nations have cared for this land from the ocean to the mountain peaks for thousands of years and continue to do so today. We thank them for their continuous care and for the opportunity to host this session today. At MS Canada, we are committed to learning from and working with Indigenous peoples to care for the land we all call home. Before we get started with our presentation, let's briefly go over a couple of housekeeping items. If you have a question, you can type it into the chat box and we will try to get to as many questions as possible following the presentations. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. This session is being recorded and will be available soon on our website in English under Informative Videos on MS, formerly called Archived Webinars, and on our YouTube channel. A Facebook Live recording will be available as well. Also, please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but instead provides information and referral to assist individuals in making their own health and wellness decisions. The views and opinions expressed in this presentation are those of the speakers and may not necessarily reflect the views or positions of MS Canada. Since 1948, we at MS Canada have been proud to be a part of a community of people living with MS, their families, friends, plus volunteers, donors, researchers, clinicians, and many more. Together, we have helped fund research, provide information and support to people affected by MS, and we've taken a bold stance to advocate for changes that allow people living with MS to live full and inclusive lives. Our current strategic plan not only lays out the roadmap in our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate, so together we can advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. Please note that during this broadcast, a couple of pop-up polls will appear. We ask that you respond to each. The anonymous information will help MS Canada better understand your experience and the impact it is having on the MS community. Your responses will help strengthen our education sessions in the future. Today's broadcast is an opportunity to learn more about aging and multiple sclerosis. At an international workshop on aging with MS earlier this year, it was announced that almost half of all people living with MS today are 55 years of age or older, and more people are getting diagnosed with MS at later ages than ever before. Yet relatively little is known about how aging impacts MS disease activity, early detection and treatment of comorbidities, along with addressing MS symptoms, progression, and disability, plus strategies to help enhance wellness, are important to improve overall quality of life as someone ages with MS. Today's expert is Dr. Kristen Crisco, a neurologist specializing in MS and neuroimmunology at St. Michael's Hospital in Toronto. She is an assistant professor and clinician investigator. Dr. Crisco has told us the support from MS Canada has and continues to be critical for my research, as I would not be able to perform this work without their financial support. Now I'd like to welcome Dr. Crisco.
Thank you very much. We'll be focusing in on aging and MS today. And I just wanted to highlight the International Advisory Committee meeting that I attended earlier that was mentioned already, where experts met to discuss some of the unmet needs in aging and MS. And we reviewed many areas of knowns, but also areas of unknowns, to try to develop strategic planning, to try to help support research, clinical care, and education of people who are living with MS as they age. Here are my disclosures. So we'll start with a brief introduction about aging and MS, and then talk about the clinical features and diagnosis of MS at an older age. We'll talk about chronological versus biological age and how that is important in people with MS. We'll talk a bit about some aging biomarkers that are coming forward in the research field. We'll touch on reproductive aging, comorbidities, and treatment of MS with age. So to start with aging, we know that MS typically begins around the 30-year of a person's life. But there's really been a shift in the onset of MS to an older age. And as was just mentioned, more than half of people with MS are 55 or older now. So people are living longer with MS, and those who are diagnosed in their 30s are aging and now maybe in their 50s or higher. But also we're seeing diagnoses in older age groups, which we'll talk about as well. So this figure here shows the prevalence of MS based on age and sex in the US. So males are in red and females are in blue. So we see that MS is more common in women. But the peak prevalence of people living with MS is really in this older age group, where we see half of the people living with MS are now 55 or older. We'll speak next about the clinical features of MS at an older age, and I wanted to just highlight some definitions. So we typically think of adult onset MS to be typically diagnosed between 20 and 40 years. And then in research, they define these other stages of MS onset. So late onset MS is diagnosed at the age of 50, greater than 50, and very late onset MS is diagnosed at greater than 60 years. Of course, we know many people with typical onset in their 20s to 40s do age and then become older persons with MS, and this is considered greater than 55 to 60, where there's a lot less research on, and we see that clinical trials of our typical disease-modifying therapies often exclude this age group. For those who present with MS at an older age, so their first attack or their first disease onset of progression starts at an older age, we see that the symptoms is a bit different than those who present at an earlier age. So we see more motor symptoms. So this includes weakness or stiffness. And we see less eye symptoms, so less optic neuritis or visual symptoms. We also see that a progressive course is more common as the beginning of MS in those who present who are older at the onset. So primary progressive MS, where individuals have never had relapses, is more common in people who their MS first presents at a very late onset stage. This is a complicated figure, but the point is that relapses decrease with age, as well as how long someone has had MS. So in people who are older, who have MS, regardless of when their MS began, they tend to have less relapses than those who are younger. But we know that if an individual only starts to have their MS symptoms at an older age, they do seem to have more relapses than those who have had MS for a longer period of time and are the same age as them. So it's this complex interplay between how long you've had MS, but also the age. And we see that if we look at the age, we see less relapses with age. But the age of onset, if they've had MS for a short time, in those few years after the disease onset, we tend to still see more risk of relapses, even in people who the MS starts, at say 55 or 60. If we look at disability, so the EDSS is a disability score, and an EDSS of 6 means time to needing to use a cane. And we see that this occurs more quickly from the disease onset in people with very late onset MS, compared to those with adult onset MS between 20 to 40 years. So it may take longer for someone who has MS onset at a younger age to need a cane, compared to someone who has MS at an older age when it begins. But we still actually see that the use of a cane may be at an older age in someone with very late onset MS because they really begin at a later age. If we look at the clinical course of MS just in another way here, we see that at older age, we see more trouble walking, less numbness, and less vision changes. And we also, just showing it in another way from a different study in the figure on the left, we see more progressive onset MS in people with MS who are older. And this is another study that looked at the disability progression. And this is where it shows the time to not being able to walk unassisted. And it shows those with late onset MS happens more quickly from the diagnosis compared with those with younger onset. But if we look at the time to being unable to walk from birth, which means basically at the age at which you can't walk, it's actually at a later age for those people with very late onset MS. So they've had MS for a shorter time when they can't walk without assistance, but that actually is happening at an older age. When we're diagnosing someone with MS at an older age, so if someone is in their 50s or 60s when they're having their first symptoms, we still use the same diagnostic criteria for MS called the diagnostic McDonald criteria. So that is not specific for age. But it's been raised that there's more diagnostic delays in people who are older because they're not fitting the typical clinical picture of what a physician may think of when they think of multiple sclerosis. In the new criteria that's not yet available but has been presented for MS, there are kind of points made that we need to be careful and make sure we're not missing someone else who has like a diagnosis other than MS for someone who's older at presentation, because there are more other possibilities that might be causing the neurological symptoms. So for one instance is stroke and vascular disease increase with age. So we would not want to misdiagnose someone with a vascular disease as having MS. It's also important to rule out, people with older age are more likely to have degenerative disease in their spine, and compression of the spinal cord needs to be excluded because it's treated differently. And then some other examples are nutritional deficiencies like B12 deficiency. Some kind can mimic certain symptoms that sound like MS, or neurodegenerative conditions also. And so we have to be careful to not delay the diagnosis, but also to be careful about not diagnosing MS incorrectly. Now we'll talk about the chronological versus biological age concept. So this is a figure really more from the cardiovascular literature, and it shows biological age on the x-axis and chronological age on the y-axis. Biological age is really the features of the individual, and someone who is looking biologically younger than their chronological age is undergoing very healthy aging. So they will be younger than what their birthday shows. Many people fall on a usual trajectory, which is in black, where they're about the same biological age as their chronological age. But some people may age quicker, and so they appear older if we look at different factors than the age based on their birthday. And a lot of this has to do with like comorbidities like heart disease, high blood pressure, high cholesterol. These features can impact the speed of aging, as could certain genetic factors. If we look to, again, the cardiovascular literature, there are many things that can help healthy aging and can slow biological aging. So two people with the same birthday, one can appear to be younger biologically if they have some of these healthier behavioral factors. So these include things like regular exercise, a healthy diet, low sodium, lots of fruits and vegetables, low in saturated fat and fast food, and low in alcohol. And if we look at medications that might help healthy aging, there are a number that are shown here that are being investigated by treating cardiovascular risk factors like blood pressure. That may help treating high cholesterol if you have it. But some studies are looking at drugs that can actually slow aging in a more general sense, not necessarily in MS. We know that MS, there's many aging processes that are happening, and people are, aging, and they may also have MS. And so this was a review article that I was part of with Dr. Jennifer Graves from the US, looking at all the different parts of aging that are occurring and how these might impact MS. And you're not meant to see all the details, but we know that aging cells impacts the immune system. So that may be why there are less relapses with age. But also aging affects some of the ability to repair and remyelinate. So it may be harder to recover from relapse with older age. So to look at some aging biomarkers, so there are some ways we can measure some of this phenomenon of biological age. This isn't something we really do in the clinic, but it's an area of research. Here are some aging biomarkers shown. So leukocyte telomere length is one of the classic markers of aging, and we will look at that soon. But telomeres are parts of chromosomes, which are in all of our cells, and they shorten every time the cell divides. And so with age, they're shorter, and there are natural processes that prevent them from shortening too much, but they are a marker of the age of cells. We're not going to talk too much about epigenetic age or senescence markers because these are still very heavily in research. But there's also another aging biomarker called a multi-marker clinical indice, which may be more close to use in clinical practice because it is a combination of metrics we can already measure in the clinic if we want to. So what are telomeres? So I mentioned telomeres are a part of the chromosome, which is a genetic material in the cell, and they shorten every time the cell divides. And if there's certain processes that might be occurring in people with MS, like oxidative stress or damage to the DNA, they shorten more quickly. And we see that if someone has heart disease or dementia or certain autoimmune diseases, the telomeres may be shorter. So this may be a marker of early aging. I had done a study when I was in fellowship at UCSF, and we looked at aging, and we saw that if we measured the telomere length as a marker of age, it seemed that the people, even if they had the same birthday, if they had shorter telomeres, they seemed to be doing worse from their MS. So they had worse disability when we used the EDSS score, and they had more brain atrophy or loss of brain tissue. And so this was a clue that, some of these biological aging processes might be at play as people with MS age. We also looked at that in some people who had their telomeres measured multiple times and saw those who had more shortening of telomeres, so more aging in their cells, seemed to do worse on the EDSS as well. Other studies have looked at this and typically are seeing signs that telomeres may be shorter in people with primary progressive MS. And other studies have shown, especially people with progressive MS, have shorter telomeres. Those with shorter telomeres may have a higher risk of converting to secondary progressive MS. And then they also seem to be associated with higher disability scores in some studies. So based on this, we don't have this available in the clinic yet, so it's not something that we measure, but it's being looked at in research, and it shows us that biological age seems to be important. And so trying to target biological and age in some way may help disability in MS. And we know that disability and progression are very hard things to treat. And so this is, an active area of research. I mentioned also the multi-marker clinical index. So this is called the NHANES Biological Index, and it's measuring basically all kinds of other organs. So not focusing on the nervous system, but looking at things like your blood pressure, whether you have diabetes, cholesterol levels, liver measures, inflammation in your body, kidney function, and lung function. And putting these all together, you can get a score showing how healthy these organs are, which is a marker of how aging is affecting someone's body. And it's found that those with worse scores on this index seem to have a higher risk of aging-related diseases like heart disease and dementia, but also higher risk of death. This was looked at in one study in the US where they also found that patients with MS seem to have higher scores, so worse biological age than controls, but there was a large range. So this is showing the MS individuals in blue, and in green was healthy controls. So we see a huge range, and so many people with MS were in a similar level to the controls, but there were some that were worse. And then we also saw in that study that people with MS who had more cognitive dysfunction seemed to do worse on this. Moving to reproductive aging. So of course our cells are aging, but so are our reproductive organs, and our hormones are changing with age. And so if we look to female aging, we have menopause occurring. And menopause, while it's defined by the time of the last menstrual cycle, it's actually something that the processes of female aging in the reproductive organs are happening earlier. And so in the 10 years before menopause, there's decline in the function of the ovaries. So after the age of 40 in particular, the ovaries are not secreting as many hormones, and that's when fertility decreases naturally. And we see estrogen and progesterone levels are starting to drop, but especially at menopause, those levels drop. In men, testosterone is also decreasing with age, and this is called andropause. That's actually something that happens more gradually. So it's happening even from the 30s that the testosterone levels are gradually decreasing. To compare menopause and andropause, I have a figure here from a study from Dr. Voskel, who does a lot of research on this. And so in red is the female sex hormones, and in blue is the male sex hormones. And we see the female sex hormones are kind of dropping more quickly at menopause, with the estrogen really dropping, whereas testosterone's starting to decline earlier and slower. And there are differences between sexes based on the chromosomes, but also the hormones. And the chromosome differences last through the lifetime, whereas the hormone differences change over time. In that, the males are losing the testosterone early, but slower, and females are losing the estrogen more rapidly at a later age. Studies have looked at menopause because this is, an important part of aging, and they've looked at how menopause is affected in people with MS, and they've found that the age of menopause is similar in people with MS to control. So it's not at a younger age. It seems to still be around 51 years of age on average, with a big range. But they've also looked at disability and how that's impacted by menopause. And this one study from Boston had shown that disability seemed to worsen at menopause. So the progression of EDSS, or disability scores, got more quick after menopause. So there are some thoughts that the estrogen is providing some protection, and the disability may be getting worse after that estrogen is lost. But we don't know the full mechanism, because natural aging outside of reproductive aging is happening at the same time. Another study from Barcelona in Europe also looked at menopause and disability progression. And this study, they didn't actually see that there was increased risk of disability after menopause in patients with clinically isolated syndrome at the beginning, when they considered the whole course of their disability adjusted, or the whole course of their disease disability adjusted for age and time since the onset of MS. And they didn't see a change in the slope at menopause. But they did see in menopausal women compared to non-menopausal women, there were some differences. But once they actually looked at the age and disease duration, they didn't see an effect of menopause itself. And that's shown here, where they saw that initial difference, but when they corrected for age and disease duration, they didn't see that difference. So we still don't have full information about how menopause affects disability in someone living with MS. Another study looked at the marker of aging of the ovaries called AMH. So this is a hormone that's actually not measured in the clinic. It is measured as a marker of fertility if someone sees a fertility specialist. But this study was looking at it as a marker of the aging ovaries, because we know, as I mentioned before, there's decline in ovarian function in the years before menopause. So it may not just be all about the time of menopause or the last period, but there may be some hormone changes that happen even before that. And in this study, they found that people with MS had similar levels of AMH to controls when they adjusted for the age. So two people of the same age who were both women seemed to have similar levels, whether they had MS or not. But they found in the people with MS, those whose levels were dropping of AMH more quickly seemed to have more disability. And they also seemed to have more loss of some of the gray matter tissue, which is important brain tissue. So to think of what some of the mechanisms are, because in research, we really want to understand why we're seeing these observations in the clinic, so that we can try to find treatments that might target them. But we see declines in this AMH hormone, estradiol, so estrogen and progesterone, all of these sex hormones in females. these might potentiate aging. So there's already aging happening, but then you're also losing hormones at the same time, and you lose the protective effect of those hormones on the brain and spinal cord. And then we may see worsening of the disability progression. We also know that even outside of MS, in general healthy populations, we see that cognitive aging and brain atrophy increase after menopause in women. So there seems to be something happening that's separate from MS, but there may be processes that interact with already having MS. And we know very much so that many symptoms that are occurring at menopause are going to overlap with MS symptoms. And it's hard to tell which symptoms are from menopause or MS, and many of them are probably a combination of the two. If we look at andropause, so in men, we see testosterone declines with age, as I mentioned. In the mouse models of MS, it actually has been shown that the testosterone may be providing some protection. So as the testosterone levels drop, that might be harmful. And we actually see that testosterone levels are lower in men with MS typically compared to healthy controls. And we see in some studies, at least, lower levels are associated with worse disability or more cognitive decline. Some studies have not shown these same findings in terms of the risk of disability based on testosterone levels. So we're still not 100% sure the role of testosterone in the MS disease course. Okay, so now moving on to comorbidities. So what is a comorbidity? So this is the total burden of illness other than the specific disease of interest. So when you're in your neurologist's office, when I have my patients with me, I'm thinking of all the other conditions they have. You know, I focus obviously on the MS, but it's important to think about the other conditions and how those may impact symptoms as well as medications, disease progression. The most common comorbidities in MS are shown here. Very common, we'll see depression and anxiety. We'll also see high blood pressure, high cholesterol, lung disease, and irritable bowel syndrome. And this figure from Dr. Ruth Ann Marie is showing how common these really are. And so we can see that, and it's also separated by age. So in red is 20 to 44 years, in blue 45 to 59 years, and in yellow 60 years or older. And we see depression and anxiety are high at all ages, anywhere from 30 to 40% or more will have depression and or anxiety. High blood pressure really increases with age. So we see that when you look at individuals with MS who are more than 60, more than half of them have high blood pressure. High cholesterol, if you're more than 60, more than 30% have that. And then heart disease is more than 20% in those who are 60 or older with MS, and diabetes is around 10 to 20%. So these are common in people with MS, and we rely often on family doctors to help us with these other conditions. What are the effects of comorbidities on MS? And so one study found that high cholesterol increased the risk of relapses. And obviously, this is something that is important to manage because high cholesterol increases your risk of stroke and heart disease like heart attacks. But also, it seems to even increase MS relapse risk. So in people with MS, they should have their regular screening when they're the age that the family doctor normally recommends cholesterol testing. That should be tested, and then they should treat it as usual if it's high. We also see in some studies that having more of these other conditions seems to increase disability, both physical, so like walking function, as well as cognitive or thinking and memory. Comorbidities also worsen quality of life and ability to work, have social participation, and also increase the risk of death. And so it's actually really, really important that these other areas are looked at. And it's important to have a good family doctor who's looking at this comprehensive care. We also see that comorbidities can affect treatment choice and the risks of treatment. So for instance, if someone has heart disease or diabetes, there are certain medications that have higher risks and we would want to avoid them. For instance, fingolimod. If someone has an active cancer, there are many DMTs, and most DMTs we wouldn't be comfortable prescribing at the same time as chemotherapy. And so having other health conditions really impacts the MS symptoms as well as the treatment. Okay, so getting to treatment at older ages. So this study from just this year showed that there are differences in treatment by age. If we look at the left, this is the late onset MS compared to the typical adult onset MS in the right. And this study showed that late onset MS was less likely to start on strong or high efficacy treatments. The high efficacy treatments are in green. And so we see that in people with relapsing remitting MS, there's less of the green here in patients who are older compared to in the adult onset MS typical group. It's also was shown in this study that those with late onset MS were less likely to switch from a moderate to a high efficacy drug. And we know that high efficacy treatments can improve outcomes for people with MS or are more effective at reducing relapses. But we also know that they have higher risks of infection, especially, which already increases with age. And so it's not that this is necessarily the wrong treatment strategy, but it's an observation that we see that less people who are older when the disease starts are starting on a higher effective treatment. This was also shown here in primary progressive MS, the far right bar for each figure, where there's less use of treatment in general in those who have disease onset at an older age. Why are there treatment differences by age? So I alluded to that a little bit, but we know that with higher age, there's actually already less risk of relapse. And the treatments we have for MS, the standard disease modifying therapies, are mainly targeting relapse activity. So if there's less risk of relapse, there's less benefit of treatment if that's the main target. We also know that with age, as I mentioned before, there's more risk of comorbidities or adverse effects. And so we worry about the risks of treatment, and doctors are always trying to discuss with our patients the risk and the benefit of treatment. And if there's more risk, that also makes us less likely to want to start a treatment. So if someone is older, they already have a higher risk of infection. And if we lower their immune system with the treatment, we don't want to cause harm. Also, there's already an increased risk of cancer with age, and lowering the immune system may not be ideal in someone who is prone to cancer or who has a history of cancer. So those who are more likely to respond to MS treatments are those who have recent relapses or MRI activity in the clinical trials. So if someone is older and they have a recent relapse, they may be more likely to benefit. But the individuals older than 50 to 55 years were excluded from many of the clinical trials for our standard disease modifying therapies. And this is really problematic because, as I mentioned before at the very beginning, half of the people with MS are older than 55 years. And if they're not in the main studies, it makes it hard for us to understand the risk and the benefit of treatment for those people. We also know that the impact of disease-modifying therapy on slowing disability progression overall is unclear. There are a few treatments that may help slow disability progression, but we really don't have a lot of information on how effective it is with higher age because, again, people of higher age were often not included in the clinical studies. This is a meta-analysis, which means they put together the results of many, many different clinical trials, which were done on many different disease-modifying therapies, which you can see the different colors in the legend on the top right. But they looked at, in the clinical trials, how effective were the drugs on disability progression based on the age of the people in the trial. One thing to note is that, again, we don't see people who are older even in the clinical trials. So the last bubble here showing a clinical trial was at the age of 50. And so we don't have people who are older than that to really draw conclusions. But they found that the older the people were in the trial, the less likely the disability progression was inhibited. This was a very similar study where they looked at the effect on relapse reduction. And actually, they found while there was some decrease in benefit on relapse reduction with age, it actually wasn't statistically different. But again, if you look, the highest age was around 40 years. So it just leaves a lot of question marks for those who are older. There's been some focus in the MS world looking at stopping treatment. So say you had started an MS treatment when you were 30 or 35 years, and now you're 60 years old. You've been on that treatment for a long time. And so as we have more people with MS living with the disease as they age and for a longer period of time, and we have more treatments, we need to understand, is there a safe time to stop treatment? So this is just one of the studies that have been done that I'm highlighting here that was called the DISCO MS trial that was published last year. And they tried to see if those who were stopping their DMT or continuing their DMT, was there a difference in the risk of disease recurrence or activity within people who were older? This study included people with all types of MS who were at least 55 years. They had to have no relapses in the last 5 years and no new MRI lesions in the last 3 years while on a treatment. And they were randomized, so they didn't know which group they were going to choose. Like they didn't choose with their doctor. Basically, they were randomly assigned whether they would continue or discontinue the drug. And then they tried to see if there was a difference. And it was a bit of a complicated study design, but they wanted to see if stopping was inferior or less good than continuing the drug. And they looked at a composite outcome, including relapses or new lesions over 2 years. One thing to note was that most people in this trial were on interferon betas or glatiramer, so some of our lower effective platform injectables. They found that there were new relapses or new lesions in 4.5% of those who continued compared to 12% of those who discontinued. So there seemed to be a difference. They could not prove that discontinuing was inferior. And it actually looked like there were less issues in those who continued. But the main reason for the difference was that they were having more new lesions in those who stopped treatment, not necessarily new relapses. But we do see here a separation where the people who discontinued in blue did seem to have more disease activity. But as mentioned, it was mainly on MRI, sometimes just 1 or 2 new lesions, and we don't really know the implications of that. Another thing to note, the adverse events, so negative things that happened like infections and other adverse events were actually similar between the groups. So we weren't seeing a lot of benefit on, say, reducing infection risk by stopping. And then it was only a 2-year study, so they couldn't look at the effect on disability progression. They didn't see a difference between groups, but we know that we need longer to see that. Unfortunately, from this study, we don't have a strong answer about whether it's safe to stop or continue a treatment, but more studies are happening. And I think this is something that is discussed on an individual patient basis between their doctor and them about how they're tolerating the medication. Are they having any significant risks, issues, or infections? And how active their disease was in the past, and trying to make a decision together. And I think as age is higher, then that is a discussion you have over time, and it's not something you decide in a single visit. Usually you might talk about it for a little while before it's a decision to be made. But if stopping, I generally monitor more closely, these patients. This study highlighted it's important to be more cautious with stopping what they call second-line DMTs, but these are higher effective treatments. And so in this study, they found that the risk of relapse was actually a lot higher in the gray patients in this gray bar, where we see that the risk of relapse was quite high in many of the patients who stopped the treatment. And this was not looking at as high age, so they were older than 45 years old, so some younger patients included. And there seemed to be really high risk of stopping certain drugs. So fingolimod and natalizumab had a really high risk of relapse if they stopped. And so we have to be cautious with certain drugs because there could be risks just from stopping them alone. And those 2 drugs can cause rebound when stopping. So we can't necessarily just stop those medications. And some strategies might include switching medications to something that then later can be stopped for patients who we want to try to get off drugs like that. If we look to the official recommendations from a Canadian group who've published treatment optimization recommendations where they discuss stopping treatment, they say that in patients who are older than 60 years with relapsing remitting MS who have been stable for 5 to 10 years, we might consider stopping treatment. Because there's a poor response, so they're not having as much relapses and there's more risk of infection. But we should closely monitor patients if we're stopping and start again if there's breakthrough activity. But a big caveat is that if there is a relapse, that could be very consequential. because it may be harder to recover from relapses. So it's always a bit difficult because we can't predict who will have a relapse with good certainty. And if someone does have a relapse and we put them back on treatment, they still may not recover from that relapse. So it's a very tricky situation and really something that we think carefully about and discuss both options and the risks and benefits of that with each patient. It's also important to think of non-medication treatments as well as symptom treatments with age. And I mentioned that healthy aging is really important because if we have a younger biological age, we're healthier for many reasons, less risk of death even, and also less disability from the MS, it seems, from some studies. And so what can we do to have healthy aging? So there's lots that we can do for ourselves, and each person will be able to do certain parts of this. But I think regardless of level of current function, there's definitely some exercise that can be fit in. And while exercise can be difficult when you have challenging symptoms, having a physiotherapist if needed or some sort of exercise routine into the day can be really helpful, both for healthy aging as well as for energy levels are generally better in people who exercise regularly. So exercise seems to be anti-aging. It makes the immune system less inflammatory. It improves certain structures in the brain, less brain volume loss, and it builds our physical and cognitive reserve. So I find that people who exercise regularly tend to do better with their MS. A healthy diet is also important because that balance seems to help aging. And then avoiding smoking, treating the other health conditions, the comorbidities like the high blood pressure, the high cholesterol, or the diabetes. And then also managing symptoms. There's both non-medication ways and there's medication ways to manage symptoms. But for instance, depression and anxiety, there's a lot of strategies for cognitive behavioral therapy that can be helpful in addition to medications in some cases. Cognition, starting to develop some cognitive rehabilitation programs for people with MS. Spasticity or stiffness can be helped by stretching, exercise, physiotherapy, as well as medications. And then bladder can also be helped by pelvic floor physiotherapy and in certain cases, medications. So what are the unmet needs? So there are many. I just wanted to highlight one issue with respect to treatment is that we really want to figure out how to stop or repair the damage that's happened and to target the degeneration that's happening. We know already from especially animal studies and also recovery from relapses that we see that repair and remyelination is not as effective with older age. So this makes it more challenging to do this. And so when drugs are studied for repair, they're often studied at younger ages when there's more repair mechanisms, but we obviously need to also study them at older ages. And then in the general aging literature, there have been studies looking at anti-aging medications, drugs that prevent bad aging, but we don't have any answers yet. We always are worried about potential risks of those kind of drugs. But studies are going on for drugs like metformin, which is a diabetes medication, but there's some suggestion that it might improve remyelination and slow aging. So there are studies going on looking at this in people with MS. And then there are studies of GLP-1 receptor agonists called semaglutide, or you may know it as Ozempic, which seems to be promising, looking at antioxidant and anti-inflammatory effects in animal studies. Now, if I have patients with diabetes who need to go on one of these medications for diabetes, I'm supportive of it, but we don't use these for MS right now. It's an area of research. So just to conclude, so we know that aging is an important driver in the presentation of MS and the disease course. And biological age may differ from chronological age, and biomarkers of aging may be helpful in research to understand this. We know that comorbidities increase with age, and the risk-benefit ratio of our current treatments differ with age. And there may be a future potential to target aging mechanisms to treat MS, and the best strategy we have now is really exercise, healthy diet. So to end, I will end off here. This is the Barlow MS Center where I work in Toronto, and I think we'll move to the question and answer.
Excellent, Dr. Crisco. Thank you very much. I learned a lot there tonight. You answered several of the questions that I was forming in my head as you were speaking. but I do have a couple of my own questions that may be of interest to the rest of the audience. First of all, are there similar accelerated neurodegenerative rates in men and women at the age of menopause and andropause?
That's an interesting question. It's hard because there's already differences in the MS disease course in men versus women. Like men, we seem to see disability progression happening at an earlier age, but it seems like at menopause and after menopause, women may catch up. We also see differences in some of the brain volume loss between women and men with healthy aging. So it's really hard to compare men and women because there's already differences happening like outside of MS between men and women as they age. So it's hard to know, but we see that definitely there are impacts of both, and these hormone changes really interact with aging. And that's still something that's hard to piece out, and it's hard to know in studies what's your best comparison group? Is it between women with MS versus women without MS? Is it between men and women with MS, or vice versa? And so it's very tricky to study, and I think also highlighted as an area we need to understand better to try to develop strategies. And there might be sex-specific treatments in the future if we can figure that out better.
Okay. Now, this next question is kind of a two-parter. I got thinking about people with MS. Do we have more comorbidities than others? And the second part to that is, or do people with MS develop more comorbidities than those without MS as they
Yeah,
age?
so it seems like there's higher risk in people with MS. Like Dr. Ruth Ann Marie has done a number of studies in Manitoba and Ontario looking at this in some of the health administrative data where it seems that people with MS have a higher burden of comorbidities than other people when they adjust for age. So when there are people of the same age. We don't always understand why. Like some of them, like depression and anxiety, are very high in young people with MS as well. And that might be related to similar brain mechanisms going on with MS and these mental health conditions. But why someone with MS is more likely to get high blood pressure or diabetes, I don't think we fully understand that, but it seems to be the case.
Maybe it's the stress. I know that drives me.
Yes,
Um,
fair, fair.
well, my thoughts about that was just that if you are given a diagnosis of MS and you think, okay, what do I need to do to age well with MS as well as to live well with MS? And the big thing is you want to cut down on the comorbidities that you could develop, like the diabetes and high blood pressure, that sort of thing. So you want to incorporate the eating better and the exercising and just living a healthier lifestyle, right?
Yeah, I think those are things like from an early point are really important for prevention, right? Like ideally, we
Yeah.
prevent getting high blood pressure and diabetes when we can. If we get it, we should treat it. And that's where it's important to have a family doctor as well as your MS specialist because we're not as focused on that part of things. And it's important to also have, that comprehensive general medical care. Some studies have shown that people with MS, while they see doctors probably more often than people without MS, like they might not focus on the non-MS part of their care, like cancer screening, screening high blood pressure, checking for diabetes. These are things we really require the family doctor to help out with, and to not just think that every symptom someone has is from their MS, to look for these other things that are definitely treatable and seem to improve MS outcomes if they're treated.
And I'm guilty of that myself because sometimes you forget, you've got other things going on with your body. It's not just the MS. Okay,
Mhm.
from our Facebook, we have a question: as we age with MS, does MS pain worsen and tolerance to it decrease?
So that's a difficult question. I'm not aware of any research studies looking at the pain and whether that increases with age. There are certainly, other factors that can cause pain with age. So, like going to our previous point, you would want to think about other things like, is there also neuropathy or arthritis? Is there some other condition that's affecting pain? And I personally think that sometimes, people assume their pain is due to MS, even though it may be due to something else. And if there's something else like arthritis of the hip that's causing really bad pain, if you didn't have MS, you would go to your family doctor, get some hip x-rays, and maybe you would, have certain treatments for that are different. And so that's where kind of having that healthcare team is important to look for what's MS related and what's not. Tolerance to pain, I think that varies by person. Pain is something that's really hard to fully understand. But there are like pain management programs outside of medications that can be really helpful. And fortunately, we have some resources in Toronto where we're able to work on some of the non medication approaches to pain, which seem to be very beneficial with less side effects.
Okay, somebody is asking from Zoom about the telomeres and measuring certain markers like telomeres. Is that done on a regular basis, or is that strictly clinical right now?
Yeah, so the telomeres is not something we measure in clinic. It's something really that's a research-based measurement. I don't know if it will be something measured in the future, but it's really showing us that this like less healthy aging seems to be worse for MS. But it's not something we measure or track over time, but gives us that impression. And so doing things that improve healthy aging, like we've talked about, like exercise and healthy diet and not smoking, limiting alcohol, these things can always potentially help healthy aging, but we don't necessarily need to like measure it. And it's not a validated clinical measure that we can test.
Okay, and another question here about Ocrevus. As we age, can being on Ocrevus cause an increase in comorbidities?
So it depends on what comorbidity we're thinking about. Ocrelizumab is a B cell depleting drug. It lowers your immune system. It can benefit primary progressive and relapsing remitting MS. It can increase the risk of infection. So if we consider infections to be comorbidities, infections can definitely be higher in people on Ocrevus of all ages, but especially with higher age. It was also shown that people with MS with higher disability levels and on Ocrevus were seeming to have more infections. And that's something that really came out and was highlighted in the COVID-19 pandemic, where people with MS had worse risk of COVID and severe COVID if they had more disability from their MS, and then Ocrevus or ocrelizumab also increased the risk of severe outcomes from COVID. Luckily, we're seeing that with vaccinations and current strains of COVID, it's not as severe as it seemed to be early on in the pandemic. But that's the main comorbidity I would think that Ocrevus increases the risk of. It doesn't increase the risk of high blood pressure or diabetes or high cholesterol, like those more common comorbidities outside of infections shouldn't be altered. There's some debate about Ocrevus and risk of cancer, which is a comorbidity. Now, early studies, there was one study that suggested there may be an increased risk of breast cancer, but that was not seen in subsequent studies. And if we look at the rates, it seems to be the same between people on or not on Ocrevus and healthy populations. And so I don't think we're seeing a higher risk of cancer with Ocrevus right now. But lowering the immune system for 20 or 30 years, we still have to see what happens because it's not been around that long.
Okay, and one more question here. Somebody's asking what treatments are available for secondary progressive MS, and that is something that normally comes up later after a diagnosis of relapsing remitting. So as you age, perhaps going into secondary.
Yeah, so that's a hard area because it's an area of unmet need where we need better treatments. Actually, for all types of progressive MS, both primary and secondary progressive, we don't have as effective treatments. We can see that treating MS early seems to help delay the secondary progressive phase. For those diagnosed in their 30s, we know that treating them with higher effective treatment seems to delay or prevent some of that secondary progression. But once the secondary progressive phase is already occurring, it seems to not just be inflammation in the peripheral blood anymore. So drugs that are classic disease-modifying therapies are not as effective. And so there's a lot of research looking for ways to target the degenerative and progressive processes in MS. And really, our current treatments are not good enough. Now, siponimod is a medication that's approved for secondary progressive MS, but it seems to only be helpful in people who have had recent relapses or recent new lesions on their MRI, such that it's not even available if that's not happened recently. And the effect on progression is, just around 20% slowing. So it's not stopping, it's not reversing progression. And this drug has significant risks of infection, heart issues in people with diabetes or on certain medications. And so it's not a medication that I find is actually that helpful, even though it's been approved. Ocrelizumab has evidence in primary progressive MS. no big study in secondary progressive, but if people have recent relapses or recent new lesions, it may help slow the progression. But that's what we have in terms of disease-modifying therapies. Obviously, there's symptomatic management for many of the symptoms, but we want a better therapy to slow the progression. Now, just recently at one of our big conferences in the fall, there was some news released about a drug called tolebrutinib that may slow secondary progression even in patients without recent relapses or new MRI lesions. So that's very exciting, but it seemed to be a small degree, and we still don't have it in the clinic. So it's something where the results just came out. They're not even published yet, so we're waiting to see that. And then we hope that they apply to Health Canada so that we can have that for our patients. But we don't quite know who would be eligible or what the risk-benefit ratio of that drug is yet. But at least there's something that may be coming on the horizon.
Something in the pipeline. That is good news to hear. Mm-hmm. Well, that actually brings us to the end of our time for questions. And so I want to thank you, Dr. Crisco, for your time tonight and the wonderful information. And as we wrap up the broadcast, we want to remind you about how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent quality information and support. You can connect by phone, email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time and can provide assistance in both English and French. We'd like you to be part of the MS community and encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. To find out how you can take action, you can check out our website at mscanada.ca. And if you have questions about any of our educational activities, please reach out to the education team by email. That's education@mscanada.ca. On behalf of MS Canada, thank you for tuning in for today's webinar. Thank you very much. Good night.